Recording in progress.
Good morning, honorable members. Good morning to the delegation from the department as well as the South African Medical Research Council, as well as our officials that is supporting the committee. I think we can start because it's now 3 minutes past 10. Marcia, can you please flag the agenda?
Good morning, Chairperson. Good morning, all. Yes, Chairperson.
Thank you, Marcia. Honorable members, as well as the delegation and the officials, I would request just a moment of silence in honor of our colleague, Honorable Baines, who was part of our committee. Can we have a moment of silence in honor of her passing? Thank you very much. I just want to welcome the honorable members to the first Social Services Select Committee meeting, as well as the delegation and all officials. Welcome to this Select Committee meeting. Honorable members, we are now on the point of the adoption of the agenda. Can I get a mover for the adoption of the agenda? Honorable Duplessis.
Thank you, Chair. Move to adopt the agenda.
Thank you very much, Honorable Duplessis. Can I get a seconder, Honorable Fanny?
Good morning, Chair. Yes, I'm seconding the adoption.
Thank you very much. Michelle, can we please get the apologies?
Thank you, Chairperson. Again, good morning to all. Chairperson, we received an apology from Ms. Adrianse as well as Ms. Breed. They have other business scheduled outside of Parliament. And then we do have an apology from Professor Ntusi, who has a prior engagement. Thank you, Chair.
Thank you, Michelle. Honorable members, can I get a mover for the adoption of the apologies? Honorable Fanny.
Thank you, Chair. I'm moving for the adoption of the apologies, Chair.
Thank you, Honorable Fanny. Honorable Duplessis.
I second the adoption of the agenda of the apologies.
Thank you very much, Honorable Duplessis. So the apologies is duly adopted. We move now over to the briefing by the South African Medical Research Council. I give over to the delegation from them. And I will request the delegation to do the presentation in 40 minutes, please. Thank you very much. Over to you, Prof.
Thank you very much. Morning, everyone. I'm Richard Matsopoulos and my colleague Nwabisa Shai. I believe, Nwabisa, you're going to start us off. So I hand over to you. Morning, everybody.
Thank you, Richard, and good morning, honorable members. I am Nwabisa Jamashai from the Gender and Health Research Unit, and myself and my colleague, Dr. Pinky Mahlangu, will be presenting on the interventions that that our unit has been doing over the past 30 years. So we will both try very quickly to run through a set of examples of interventions that we have been delivering in our unit. We'll start with this presentation. We'll talk about how we work in order to arrive at the design and review as well as evaluation of our interventions. And we'll cover a few of the over 20 interventions that we have developed and designed as a unit, which revolve around preventing violence before it happens, or stopping it from repeating, as well as secondary prevention when the violence has already started, and trying to stop it before it escalates, or ensuring that women receive the justice or the healing that they, as well as other survivors, receive the justice and the healing that they need. So over the past 20 years specifically, we have been working on a series of interventions, and our work culminated 10 years ago to an intervention that we conducted in 13 countries in Africa as well as Asia. And this set of work led us to arriving at a complex understanding of the drivers of violence against women and girls, where we were able to come up with a conceptual framework for understanding what drives violence, what leads to men's perpetration, as well as women and children's victimization, and key issues that affect our country in particular, which are also acknowledged in the strategic plan, the National Strategic Plan on Gender-Based Violence and Femicide, as well as the Femicide Prevention Strategy, are some of the issues around structural inequalities, especially those related to economic issues, gender inequalities, which are also acknowledged as a social determinant of health, as well in the SDGs. And so our work is often guided by digging deeper into understanding those drivers, and then working towards a broader understanding of how to then lead this and help the work to guide us into the key elements that we would then be working on, and as a framework for us designing the interventions that work. So what we have is this kind of framework that guides the design of interventions that we're working on, and key among these is a theory of change that is robust, that takes into account the local context, as well as the multiple drivers, and also the gender and power issues that are often like the driving forces behind the disempowerment and the victimization that we see in our work. And key among these elements that we consider in the design of effective interventions is this training and continuous support of well-equipped staff to deliver the interventions. So quickly, I will just go through a school-based prevention intervention that we have done. And this intervention was called SCOCO for support, for success rather. And this was made up of three components. One was a workbook for life orientation that we had adapted for the project, as well as positive discipline training that was offered to educators, and a family a program between parents and their teenagers who were in grade 8. And we conducted these the workshops particularly for the parents and their teenagers during Saturdays where the parents were mostly available. And the findings of the work that we had done with these three components, we saw an increase, rather a decrease in the incidence of physical and sexual intimate partner victimization among learners. And we saw a reduction in bullying, an improvement in gender attitudes, and a better communication. But because we also worked with parents, we saw some improvements with parents, where we saw parents, as an example, showing improvement in their stress that they were experiencing with parenting. And there were reports of lower corporal punishment being meted by educators, and improve positive discipline methods that the educators began to apply. And I'll hand over now to Dr. Pinky Mahlangu to present one of the projects that we are implementing. Thank you very much, Prof. Shai, and good morning, honorable members. So we are moving now to the higher education setting, where we've also developed interventions since 2019, where we worked across 5 provinces in South Africa with TVET colleges and universities. And really here, we conducted formative research, which showed us that students are actually experiencing high prevalence of sexual violence and poor mental health. After that formative research, we then developed an intervention that we call Ntombi Vimbela, which is a sexual violence prevention and mental health promotion intervention for female students. And for those who are wondering which female students did we work with, we worked with first-year female students. And the reason for that is that we found that when they come to universities, compared to other students, they are more vulnerable to experience sexual violence. And because of the setting that is still unfamiliar to them, they're still adjusting. There's also a lot of poor mental health that they experience. So this intervention was designed for them. We targeted the first-year female students between the ages of 18 and 30 years old. And just to explain the name behind it, it's called Ntombi Vimbela. Ntombi is a Zulu name or a Xhosa name, and Vimbela is really to resist in English. So the intervention consists of 10 sessions, which are on my right today. You can see the different components that is covered in the intervention. And because of time, I'm not going to take us through that. So it's peer facilitated in that we work with students. We employ and train them to run these sessions with their peer first-year female students. Is based on participatory delivery methods where we use a lot of brainstorming. We allow students to reflect, to work in groups, to discuss and share amongst each other as they learn and go through these different sessions of the intervention. So we piloted the intervention across different settings. We recently worked at University of KwaZulu-Natal, and lately, this is what our students said after going through all of the sessions in the intervention. They said that it helped them to be aware around sexual rights and consent. Many of them, they started understanding what sexual and gender-based violence is. They were able to know what support they can get should they experience sexual violence. They also said that it empowered them with skills and knowledge around accessing the mental health services, and it also boosted their confidence and resilience to recover with sexual violence. They acquired skills to assess the risk of sexual violence, to know what are the, in what settings, which people, in what circumstances am I likely to be violated? And what can I do should I find myself in a sexual assault risky situation? They also said that it sensitized them around the gender norms that are driving the sexual violence. They are now able to identify even some of the rape myths that contributes to the high risk of sexual violence, but also started questioning the patriarchal privilege, which is in many of our societies and a key driver of this violence that we are seeing amongst the students. They said that the intervention helped them build a sense of self-worth, self-confidence, self-efficacy, and they are now able to communicate effectively around, their experiences and even in their relationships. So I'm moving also to another intervention that we did with the lesbian, bisexual, and queer women, because we found that initially we started working with the female students who are dating men, but we found that there were those who were in same-sex relationships and those that are dating both men and women. So there's another intervention that we piloted amongst students, which is with the lesbian, bisexual, and queer women. This intervention, you can see that it consists of 12 sessions. There's an addition of 2 sessions. So it's an adaptation from the previous one, but it's tailored uniquely for these different students who are dating other, who are in homosexual relationships. So we found that in this intervention, participants said that it improved their communication skills, it helped them to manage their problems better, help seeking was improved as well. It also helped them assess the risk of sexual assault and to know what to do should they find themselves in risky sexual assault. What was also interesting with this one is that it shifted their use of sexual violence, because remember, in these same-sex relationships, there is no man, but we found that also there is a lot of violence that is happening, physical, sexual violence, and you find that it's bi-directional in that the perpetrator is not the man, is also the female. So in this intervention, we've seen that it started shifting their use of sexual violence. But just to highlight that some of the things that they said they found difficult in this intervention, they found it to be triggering. They found it to be amongst those who were experiencing sexual violence. They said that, you know, they felt triggered. Even the mental health issues were difficult to deal with. But what was good is that they had support. They had social workers. As they were running through the sessions, they could go and speak to a social worker. But they found the intervention to be a safe space where they could share about their experiences and get support from people who can be there for them. We also have a colleague of ours who is working with men in universities and TVET colleges, working on an intervention that aims to reduce perpetration and support men students and improve their mental health. So this intervention is also currently co-developed in 2 provinces in South Africa. Work is ongoing, but what we are seeing from the formative research that has been conducted is that, you know, male students spoke about how the setting at universities, the campus culture, the alcohol drives the perpetration that they do in these settings. So we'll come back again, we'll present how this is going. We are currently at the stage where we are developing it, and we'll be testing it soon amongst students, and we will know what, you know, the intervention is able to achieve amongst male students. Thank you, Dr. Mahlangu. So I will now tell of a story around the prevention of gender-based violence through an intervention that over the past 20 years, the Gender and Health Research Unit has adapted this intervention both in South Africa in variations from when we started with a gender transformative prevention intervention that reduced men's perpetration of violence against female partners, their drinking patterns, and reduced the risks for HIV infection, to 2024 when we added an economic empowerment component to that intervention, and we saw results. And when we took that intervention and conducted a rigorous randomized control trial in South Africa, and we found improved livelihoods and economic empowerment for men and women who are living in informal settlements, as well as saw the sustained change in reduction of men's perpetration of violence, particularly young men in informal settlements. And with the learnings that we had obtained from the 2014 trial, we actually adapted for 2 evaluations that were conducted in Tajikistan and in Nepal, and we saw reductions in the perpetration of family violence in those contexts. And we saw that the model of participatory design group-based programs that start with the kind of pattern of delivery that Pinky described in the Ntombi Vimbela work. We apply the same methodology in terms of how we design interventions, and we've been consistent over the past 20 years, to the extent that in 2023 we completed another iteration of the stepping stones based work where we were working with young people, and we found that when we adapted the interventions to include a mental health component, we found that there were sustained changes in both improvement of mental health for women, as well as in the reduction of perpetration of violence by men, as well as women's reported victimization. And currently we have a project that Professor Skweyiya, who's also working on the men's version of Stepping Stone in the higher education setting, we found he's also currently working on an iteration of the intervention that is working with couples. So this is a bit of the evidence around the work we have done with the young people where we have the mental health component of the work. And we also have now the Zithandani project that is focused on changing the gender transformative challenges and issues that are informing or influencing the perpetration of violence in those relationships of young people in formal settlements. And this work, while it is ongoing, we wanted to just show an example of how iterative the process is when we're adapting interventions. So we start with some qualitative research that is informed by young people who are going through, the same issues that we have in our communities that we're seeking to address in our intervention. And we also follow a theory of change, and the co-adaptation process works in the way that the theory of change is developed not by the researchers, but in tandem with the young people from the community that we're working with. And what is now going to take place with the Zithandani project is that they are going to pre-test it, and they're going to work towards evaluating the adaptation of the intervention. And so we're seeing some results, and particularly the approach of co-developing the interventions helps to promote healthier relationships. We've done some work also with women who have been raped in a context of the rape impact cohort evaluation study that has been presented before. And what we did is that we took the learnings that showed us that women who have been raped are at twice a risk of contracting HIV, and we adapted a mental health component of the different pieces of work that we do to try and strengthen the work towards understanding how do we address mental health and reduce the vulnerability for women who have experienced rape, so that we prevent them from contracting HIV. And we found that actually there is these methods are feasible. It is possible for us to improve mental health issues like depression and anxiety. And this work is ongoing, and we are working towards a next iteration of this work. And the last project, quickly, is that we have been approached by the Department of Justice to develop a femicide prevention strategy, which is meant to be appended to the National Strategic Plan on Gender-Based Violence and Femicide. And what we had identified from the work that Justice is doing is 2 tools that are focused on reducing the risk for women to experience more violence, and also to find safety plans that would work for them. And so we've taken these 2 tools and we've started taking them through a process of trying to encourage, trying to learn how well they are working, so that we can develop information on the kinds of approaches that work to prevent femicide. And currently we are at a stage where we know that we are working with women who are already experiencing violence, and that we're trying now to understand how the ways in which we can use tools that are implemented by the police, by social workers within the justice and the social services sector, how those tools can work best. And we are now in a process of analyzing the tools that we have adapted, which looks like this one. And we are going to be updating the committee soon. Thank you very much. Over to you, Richard.
Thanks very much, Nwabisa and Pinky. I'm changing tack slightly, presenting from the Burden of Disease Research Unit. Our brief is slightly different in that we try to develop health data that are useful for decision-making, but I also have some experience working in the violence and injury prevention space from UCT in the Burden of Disease Reduction project. So I'm going to take some of the learnings from working in that environment for my presentation. Next slide, please. So a useful starting point for this discussion is just to look at the official data coming from Statistics South Africa through the death notification system. And you can see that those data are very unreliable in that they tend to show that most injury deaths, non-natural deaths, are due to what are we calling unspecified accidental factors. And the reason for that is that there's a missing information field on the death notification form. The manner of death is not captured, so it's quite an easy fix, but it's been enduring for a long time. The solutions are to change the form, obviously, also train doctors in better certification of cause of death. Nevertheless, next slide, please. A lot of our effort in the Burden of Disease Research Unit is to conduct mortality surveys, which we do alongside Nwabisa's unit, to try and get a better perspective of the profile of injury deaths. And so this is the information that informs our burden of disease studies. Essentially, we do these surveys roughly every 10 years. And you can see the profile is vastly different. You can see that it's mainly homicide and road traffic injuries that drive the injury mortality burden in South Africa. I'm going to focus largely on interpersonal violence, just due to limited time and just so that there's consistency with the previous presentation. Next slide, please. And it's important to know that the mortality data only tell one side of the picture. There are, of course, many non-fatal injuries. In addition to that, we also need to consider violence as a risk factor for other causes. So if you look at the table on the left, you'll see that interpersonal violence injuries rank as the 5th leading contributor to the disease burden in the country. And the chart on the right shows where that quantification is coming from. It's the intimate femicides and the interpersonal violence injuries. But those are just a small portion of the overall burden. Violence contributes substantially to infectious diseases such as HIV through sexual assaults, non-adherence to medication, and so on, as well as mental health conditions. So if you look at the contribution of interpersonal violence as a risk factor, it ranks 2nd and contributes almost 9% to the disease burden in South Africa. Noting these data are from around 2012, so things have possibly gotten a lot worse. Next slide, please. We've also attempted to cost violence. This is the first comprehensive, not quite comprehensive, we're as comprehensive as we could make it. We've had to leave out some costing dimensions, but essentially what we've looked at are the tangible costs and the intangible costs. First order, the immediate costs, and the longer term costs, the second order costs, and then the intangible costs, which are the costs borne by community members and families, essentially. And what you're seeing is that the tangible financial costs that would accrue to the fiscus are were 129 billion in 2019, accounting for 2.3% of GDP. The intangible costs, however, 7.1, almost 3 times higher than that, meaning that the total cost of interpersonal violence equates to about 9.4% of the GDP in 2019. But I think you'll all be aware the murder rate has increased, and so that cost is probably above 10% now. We're currently updating those estimates. Next slide, please. So part of the work we do alongside the Gender and Health Research Unit, I've mentioned the all injury studies, which we've done in 2009, 2017, and 2020 and 2021. Nwabisa's and Pinky's unit have also look at female and child homicide and look at very detailed information from both the mortuaries and the police investigations. In 2017, for the first time, we did this for male homicides too. And so I'm going to briefly report back on some of those findings. Next slide, please. So it's important to recognize that males contribute substantially as victims of homicide in South Africa. There's a lot of attention on gender-based violence and violence against females, rightly so. I believe the rates in South Africa are nearly 6 times global averages. But it's important to note that for males, the homicide rates are close to 8 times global averages. Pardon me, sorry, it's That's close to 7.5 times global averages. You can see that the male rates are significantly greater than females for all age groups except the 80+ category, higher but not significantly so, and up to 8 times higher in the 15 to 44-year age category. I mentioned, of course, that females bear a considerable burden from other causes as well. So if you look at the picture overall, the burden is actually rather similar. But if we're talking about homicide specifically, we can see a lot of the burden is borne by males. Next slide, please. So very briefly, this first time that we did the study on male homicide, the second phase looking at police investigation, the aims were to look at the relationship between victims and perpetrators, to describe the epidemiology of perpetrators, and then look at the victim and perpetrator profiles for males killed by males versus males killed by female perpetrators. Next slide, please. So it was a formative study where we've tried to present all of the data in the first paper. There are several analyses that will follow these. You can see there are 3 enormous tables that I've snapshotted on the right for each of those aims. So we set out all of those results. It's impossible to go through any of those tables probably in a single presentation, let alone try and squeeze them into part of this one. And so I'm just going to pick out a few results of interest. Next slide, please. Firstly, looking at the perpetrator sex, I think, no, if we could, okay, all right, we can do it all in one. The perpetrator sex, the pie on the left, not surprising, I think you'd find that 93% of the perpetrators of male homicides were other males. And it's a 13-to-1 ratio. It's probably even higher for females, the female perpetrator by sex relationship. What is interesting, though, is if we break this down and look at those 93% of male perpetrators, the next slide, please, there we go. You'll see that the relationship with the victim for 63% of men killed by men are acquaintances. A fair number are strangers, very few family members. Whereas if you look at the female perpetrators of male homicides, most of them are family members. In fact, 60%. It's more than 200 men that are killed by intimate partners. And so there's gender-based violence within the family where men are the victims too. I think it increases our IPV rate, intimate partner violence, homicide rate by about 20% when we consider the male victims. The acquaintance aspect is interesting though, and Nobisa's mentioned, or Pinky mentioned, I can't remember who of you mentioned the role of alcohol, but if we could go to the next slide, please. In the first phase of this study, when we looked just at victims, we saw that male homicides were clustered around festive periods, December, April, July and September school holidays and weekends. We saw that disproportionately more men than women were under the influence of were killed, particularly on Saturdays, a 9-to-1 ratio. And also had, for those where we had blood alcohol results, that was 11-to-1 ratio of males to females. So men and drinking a clear driver from the first phase of the study. And this is borne out when we look at perpetrators for alcohol use as well. 50% of homicides by acquaintances involved alcohol use. 41% by family members. And you compare that to other drug use, which was only 9% of incidents overall for male homicide. It shows clearly the role of alcohol. And if we look, I don't know, I'm sure we all remember the alcohol bans during COVID, and the chart on the right shows the dramatic drop in deaths, that solid bar, that drop immediately with the imposition of the alcohol bans, which are those periods which are highlighted in red and pink. They drop dramatically below the expected number of cases immediately after the imposition of an alcohol ban. So I think a very clear indication of the role of alcohol, not just for violence, but for injuries more broadly. Next slide, please. I'm not going to summarize any of these, but just to note there are multiple studies looking at the effects of those alcohol bans for various outcomes, for femicide, for suicide, most recently on residential fires in Cape Town. We've seen these results from mortality data and also from non-fatal data in the trauma units. Next slide, please. So you would expect that this is the perfect opportunity for us to be focusing our efforts on reducing alcohol harm. I was involved in the alcohol harm reduction policy in the Western Cape, developing a green paper, a white paper, and this was in 2018. The expectation was for a bill, but that never materialized. And I think translating that evidence-based alcohol harm reduction policy into an act is not going to be happening in the Western Cape, despite the fact that the white paper was approved by the provincial cabinet. It's not the only example. Obviously, these are just some national examples of efforts to strengthen the regulation of alcohol that have all failed or are lapsed or are in limbo. So there seems to be a dearth of political will and intent to actually take on alcohol in a more sustained manner. Next slide, please. I don't want to go through this in any detail, but just to note that if we look at the perpetrators of male homicide, we see that unemployed perpetrators are overrepresented across all victim-perpetrator relationship types. Next slide, please. A whirlwind tour of risk factors, and I'm sure many of you are familiar with the ecological model and how we frame things according to the proximal downstream risks for family members and your own biological risks. I've mentioned males and young males would be examples of biological risks, and a plethora of risks across the ecological spectrum in South Africa. I'm not going to read through all of these, but if you cast your eye across any one of these, you will see, next slide, please, that we have risk factors in abundance in South Africa. So it's not the case when something dramatic happens that there's a special South African circumstance that gives rise to forms of violence. It's the fact that we have all of these risk factors in abundance. Next slide, please. So Pinky and Norbisa's presentation set out some of the intervention strategies that we can employ, but noting that there are multiple intervention strategies for all of those risk factors. And it's very difficult picking which ones to focus on. And so what the WHO has done, which I find quite helpful, is to group the interventions for violence prevention into 6 key themes. The first is investing in early interventions. Second, increasing positive adult involvement. Third is strengthening communities, and so giving communities agency to protect themselves from alcohol, for example, and how alcohol is regulated in their communities would be an example of that. Changing cultural norms, reducing income inequality, and then improving criminal justice and social welfare. And I've highlighted criminal justice because that seems to be the solution we always turn to after something profound has happened. But this is just one of 6 strategies, and it's only half of one of those 6 strategies. There needs to be a concomitant investment in social welfare alongside the investment in criminal justice to make substantial inroads. The other thing to highlight from this slide is most of the strategies require a long-term focus. And that is, in my experience, not always politically palatable because political cycles are 5 years, and most of these interventions take 10 to 15 years to realize. Next one, please. Next slide, please. So the challenge is really to try and achieve balance between addressing some of those long-term social fabric issues, but at the same time, I think policymakers, politicians need a few quick wins to show that things are actually working. I've already gone through alcohol control as a potential quick win, and I think that's undeniable when you see what's happened during COVID. Now let's quickly look at firearm control. Next slide, please. So using police data, you will see that there was a dramatic decrease, well, not a dramatic, a gradual decrease in homicide over the last 25 years to a point. What happened? Next slide, please. What happened from about 2011, 2013 is that there's been a gradual increase. Now, the police don't routinely release information on how many firearm homicides there are. And I've omitted the Firearms Control Act in 2001, which there are several studies showing a dramatic decrease in firearm deaths coinciding with the imposition of that act. Next slide, please. But if we focus on those years where the police have released information on firearms, you can see that practically all of the increase in homicide is due to the increase in firearm homicides. This is consistent with what we know from around the world. Most of the variability in murder statistics when you compare countries across the world is that countries with high levels of homicide invariably have high levels of firearm homicide. It's the main varying factor. There's very little difference across countries when you look at other mechanisms of homicide. So this isn't a violence reduction strategy. It's when violence occurs, it limits the severity or lethality. And I think we haven't done a good job since the Firearms Control Act had an effect early in the 2000s. We haven't really kept our eye on the ball, in a sense, in ensuring that enforcement is sustained. Next slide, please. So in conclusion, I've presented a gendered analysis, which I think is important contribution to the South African violence prevention landscape. I think as we reach a point with some of the gender-based violence initiatives where it becomes difficult to make more inroads, there needs to be a focus on some of the upstream factors. And to do that, we need to look at other metrics such as rates of male homicide to try to shift things. So we've highlighted some patterns and prominent risk factors. Male homicide doesn't seem to be recognized as a public health priority, but what this analysis or the presentation has shown is that despite the evidence for some of the upstream risk factors, that evidence has not been sufficient to sustain evidence-based prevention action. And there are repercussions in ignoring that evidence. I think poorly implemented quick wins, such as firearms, can become quick losses. And this in turn compromises the possibility to implement other evidence-based interventions. Next slide, please. Just to note, of course, that none of this work is done in isolation. We're grateful to the participation of government departments, the police services, our fieldwork agencies, research colleagues across the MRC and funders. Next slide, please. Also to note that in a year from now, the second, almost right in the middle we will be right in the middle of Safety 2026, which is the flagship event on the prevention calendar for injury prevention, to be hosted in Cape Town. Next slide, please. There's several thematic areas. I wanted to note on this slide, I've got the Department of Health grade out there, because I'm not quite sure the extent of support, but my understanding is that the Department of Health is supposed to be a co-sponsor of the event, but I don't think that's been formalized yet. So that's, but to note, this is being co-sponsored by the World Health Organization, the MRC, and the Foundation for Professional Development are the hosts. Next slide, please. I don't think, Nobisa, I think we can go to the these are just some of the thematic areas. I think we're out of time. So I think I'll end now. Just to note, the call for abstracts is open. So if there are colleagues that are interested in presenting or sharing research, it's a great opportunity. And thank you for your time. I'll pause there.
Thank you very much to Dr. Shai, Dr. Mashlangu, and Prof. Richard. We really appreciate the presentation. Honorable members, we heard the presentation. Is there any questions of clarity or any other question regarding the presentation? Honorable Du Plessis and then Honorable Fanny.
Thank you very much, Chair. I just have a few questions, and thank you. And this presentation is wonderfully detailed and robust. There's little conversation about police intervention and also in addition to police intervention in the policing, and there's no conversation about punitive measures. I found quite often GBV is not perceived as a crime on the ground whenever I engage with residents, and it really does need to be perceived as a crime because it is a crime. Additionally, our police officers are not fully equipped to address post-violence, both in victims and in perpetrators. And just a small example of just reasonably silly example, but it shows the attitude that many police officers have towards rape culture in South Africa. I jog at Zoo Lake often, and the one morning I jogged at Zoo Lake, 5 police officers catcalled me and approached me quite aggressively, and it was I obviously fought and was quite loud, but not everybody is, and I think we really need to improve our engagement with SAPS to ensure that police officers understand the impact of GBV on both the individual as well as no longer protecting the perpetrator, but punishing the perpetrator with real punitive measures. I really would welcome the mention of psychosocial support in one or two of the interventions for both the perpetrator as well as the victim. Are we going to increase this? And this links to the question, where have your interventions been rolled out specifically? It was mentioned with the Department of Higher Education intervention for first years that it was in 2 provinces. Which provinces was this rolled out in? Then are we looking into corrective rape? It is something that a lot of people do not necessarily mention or talk about, but it is, in my opinion, both a hate crime as well as assault. And what is being done, or is there any research that is being done with regards to corrective rape? Then there's a lot of transversal or whole of society approach within this presentation. I'd just like to find out exactly which departments are working with you on this, because it takes more than just, as you have said many times, at the Department of Women, Children, People with Disabilities or Social Development. It really takes almost every sector of society to step in, from the Department of Health to give proper data, to Department of Police, to Department of Basic Education, Higher Education. So which departments have been engaged with? Then there is quite a big issue, and it's not mentioned, and I think we often skirt around it. We are all aware of the system of sex for jobs within the public sector. And until our leaders and politicians all this, apologies, I just need to quickly get the dog silence. Until we have a conversation about what is being done to develop and create an awareness amongst leaders in the country, both politically and all other parts of society, to ensure that sex for jobs doesn't happen, that people actually understand that othering has a massive impact on GBV. What is rape culture and how does that impact? Just an interesting aside, the GBV rate in India has increased under a government that is divisive and divides the country into various tribes, and where tribalism is incredibly high. So what are we doing as politicians, and also could we look into that for regards in research? Then it is incredibly interesting that it is mentioned that there are long-term challenges because of the 5-year term, and it is something that we do need to address more directly as well, to ensure that we have a sustained approach regardless of political buy-in or processes to address this scourge in society. It is the triple burden of disease. It is not only costing us psychologically, but financially in this country. And then I think that is where I am going to stop, Chair. Thank you for your indulgence.
Thank you very much, Honorable Du Plessis. Honorable Fanny, over to you.
No, thanks, Chair. And also, once again, let me greet all the honorable members and administrative or audit staff. Let me welcome the input by professors and the team that have made the research in order for us to deal, and with these challenges, social challenges, with a better understanding. But my input, first and foremost, I think it's something that we can disagree about. Also, that look, these questions are not, only, are not only, the question of, our society that does not want to, or that wants to behave the way it does, but it is an ideological question that we are not, as politicians, refusing, in fact, to address. Therefore, it tells you that we will never be able to get to the bottom of it. If we want to get a peaceful society with minimal and with no violence, I think we need to go back in terms of how structurally, our society, was formulated. Why, for instance, only few, people with a lot of resources that are owning in this country. The means of production are concentrated in a particular race, and even in that particular race, a particular gender, which is male dominated in character. Therefore, the society now is taking that particular shape, that the same, gender in a society accumulated, the wealth, everything that they are owning with violence. That is why you discover that even in any race, in any culture, the question of utilizing, violence in accumulation of whether it's power or any means is informed by a question of violence, and it has been accepted, but now when other races are taking, specifically those who are poor, are following the same trend, it is being criminalized, and it what is causing our society to have these challenges. The question of culture, for me, it also followed the same trend, because one will argue that culturally, and traditionally, issue of race was never been an issue up until we reached a particular stage, of our societal development, where violence became acceptable, where violence was used in order to undermine, other races and other cultures. Therefore, it became a phenomenon. Then I think for me, it must be a starting point. And then the question is, how do we address now, this question in a current situation? Because I can assure you, the studies have been done, and the studies will be done. But the question of the economic competition, the strata the structure of socially, the structure economically, and so on, is continues to be the same, is not yet addressed. I will tell you now, there is a new trend that we find in our society. The one that is, of people who are going house to house, taking whatever they want to take, using force. It's criminalized indeed, but People are being arrested, but the question that we must ask ourselves, why are these not being reduced? Because we have not yet addressed the question of your economic and social structure that we are currently confronted with in our society. Therefore, what I'm trying to say is that the study, Prof, is perfect. I fully accept it also in terms of the findings. But once we are not, putting a more emphasis on the question of an economic structure, we are going to have these problems. You will go and report the case to the police. The police will have their own behaviors, will have their own interpretations. People are being sent to jail, but people are coming back to jail committing the same challenge, the same crimes again. Women against women violence in the current society is not being regarded as we are correctly articulating it, that it is not fully reported, but it is equally the same violence that is being attached when a male is committed the violence to other males and any species for that matter, because it is not acceptable. So my input, in as much as we are agreed that the symptoms that we are trying to address at a societal level, the practical example is you go to any town or any city. When we're doing the studies, you look in terms of how the high rate of these crimes, where are they concentrated? If you take your child, from human settlement areas, you take it to university, it's obvious that child, the behavior of that child, you cannot expect, because there was no counseling. That child was not prepared to go there. It's obvious that that child will obviously be confronted, because it's overwhelmed by the environment that you are interfaced with. Then that child, when it goes back to the community now, you started to university, you go back to Soweto, where I'm staying, very, very high, a number of, inactivities. The only activity that is there, that is learned, is the same violence of whatever that you want. If you are a male, or you are a male, a child, So I'm trying to say, I agree really how we are approaching the symptomic of the challenges, Prof. They are good, but we really need to get to the bottom. If we are not doing this, we are not going to be able to address that, as we are currently interfaced with. You go here in Cape Town, we look in terms of who are these people who are performing these challenges. The perpetrators mostly, on the side of the poor people, that have no economic and social activities, and you see that the number is on a daily basis is escalating. The violence is escalating. You have police, people are being arrested, people are being killed, but it continues and is accepted, as a norm, because for one to be able to acquire or to that's what I'm trying to raise, that up until we address the structure, the structure of society, where a male domination, specifically white male domination, because it is the current challenge that are currently confronted. So other races are copying what they are getting. You go to to your work environment, the situation is the same. People are getting small time with their families. They are forced to work. And support the presentation. Thank you very much.
Thank you very much, Honorable Fanny. Prof and Doctor, I will give over to you to give feedback regarding the questions of the honorable members. Thank you very much, Dr. Shai.
Thank you very much, Chair. I think I will give an opportunity for Pinky to start, then I will come in, and then Prof. Richard will also come in. And I think, yeah, so I think there's quite a lot that we could cover, but yeah, we've identified which parts we could comment on. Thank you.
Thank you very much, Chair. I think I just want to start with Honorable Duplessis' comments. Thank you very much for those. Just to answer your question around where we worked with the interventions. So the ones for females, we worked in 5 provinces. That was Mpumalanga, Gauteng, Eastern Cape, KwaZulu-Natal, and Limpopo. And the interventions with the men are currently piloted in Gauteng and in the Eastern Cape. So that is the spread of the interventions so far. And really, this is not to say that we're not planning to go to other provinces, but as you know, that resources are required. This is just the start of work that we are hoping to increase and expand to other provinces as well. Yes, the issue of corrective rape, I have not spoken to that, but we've seen that corrective rape is one of the key drivers that is linked to the sexual violence that is experienced by the gender diverse students, those that are identifying as lesbian, queer, and bisexual. We've seen that, when we did the formative research, they spoke about how most of the men harass them and question their gender and say that, they've not tested sex with a male person, hence they are identifying the way that they do, and how actually many of them have experienced the corrective rape as a way of trying to change who they are. So it is a big problem that we have kind of integrated in the intervention with the men. So Professor Skweyiya is addressing some of those challenges in the intervention with the male students. So the issue of sexual harassment is big as well. Just to, agree with you on that point, it's one of the big problems that we've seen, not only between students to students, but also between students and the lecturers. The issue of sex for marks continues to be a key driver of the sexual harassment experienced by the participants in our studies. So, let me give it to Prof. Shai just to reflect as well.
Thank you, Pinky. So I will try and combine my responses to Honorable Duplessis and Honorable Feni. So just on the question of whether the interventions that we develop are scaled up, I would like to just say that we have these 20 years of interventions having been developed, and where we've shown that different elements of the interventions could be adapted by civil society organizations who are implementing on the ground. And that kind of learning has been integrated into the design and the development of 3 documents that guide our policy in South Africa currently. It is the National Strategic Plan on Gender-Based Violence and Femicide. We're very much a part of the design and the development of that document, as well as an articulation of a prevention strategy that is encapsulated and captured in a document called the Comprehensive National Prevention Strategy, as well as the integrated national femicide prevention strategy. So those 3 strategies provide at least the guidance for how to adapt the interventions that we have provided evidence for as the South African Medical Research Council, as well as other researchers in South Africa. And what we have done is that we have provided guidance in the second slide, where I showed the 10 elements for effective adaptation and design of interventions. that actually is a guidance that is provided to all stakeholders who are looking to adapt the interventions. So the What Works program provided us with the practical means for adapting the work that we do in a way that would be contextually relevant and where people could take the key elements that enable them to adapt into their existing work. And so the one mechanism that I know of that is routinely and targeted at integrating the evidence into the work that we are doing in South Africa, it is the Gender-Based Violence a Response Fund, one, which is currently supporting over 100 NGOs and to deliver prevention across the country, across the 9 provinces. And the challenge has always been the capacity of NGOs to understand how to take on and create evidence-informed programming. However, there is work and there's concerted effort under the leadership, the current leadership of the fund to try and support and build capacity for NGOs to implement those programs. So what we do as the Medical Research Council is to develop the evidence and to ensure that we have translated it well enough that the other stakeholders, policymakers, community-based organizations understand how to use the programs. And we keep looking at the gaps. Hence, we have 20 years of stepping stones, which began as a gender transformative intervention to help us prevent gender-based violence and HIV, to now having iterations that look at economic empowerment. And we had taken lessons from the structural inequalities that continue to persist and make it difficult for young people, especially in marginalized communities, to be able to avoid the behaviors and other risks that are connected to violence perpetration or victimization. We built on the livelihood component. We tested it. We found that it actually works to improve livelihoods. And so we do tackle not only the economic empowerment with the intervention, but also the normalization of violence, acceptability of violence in communities. And so we've taken that and taken it and acknowledged that there was another issue that we needed to tackle, is the mental health effects of having been exposed to violence over a long period of time. And we acknowledge that exposure to violence in South Africa, which is what Richard's message is that violence in South Africa is endemic. And what happens is that exposure with the work we have done, including the work understanding what are these drivers. The issues I didn't get an opportunity to present in my presentation was to highlight among the drivers the exposures in childhood. So whether it is childhood neglect, whether it is physical or emotional and sexual violence exposures before young people turn 18 years old, those also matter, and they really influence whether young men will go on to perpetrate or young women will continue to be victimized when all of them are in adulthood. So we try and take on these different elements and learnings as we continue to rigorously evaluate our interventions and we continue to take those gaps and adapt them so that we can continue to help to improve our understanding and also to improve the material that community-based organizations as well as policymakers are doing. And hence we have now arrived at a stepping stones version of the intervention that's designed for men in higher education because of that gender transformative element. And we saw that from the 2006 evaluation, we could reduce a problematic alcohol drinking amongst young men in that intervention. And so Professor Square is taking all of those elements and trying to infuse it with the learnings that he, along with Dr. Mahlangu and Professor Machisa, have learned around working in the higher education setting, especially to try and reduce violence, sexual violence exposures for young women in their first years. So we continue to deliver and to address all of these issues. However, we cannot with an intervention provide impactful material when we do not tackle multiple factors all at once. However, the resources, they need to be available for community-based organizations to continue to deliver the programs that are much needed to address the violence that we see, especially affecting women and girls. So over to you, Richard. Thank you.
Thanks so much, Nobisa. I'm struggling to think of anything that you've left out in responding to the intervention aspect. But just to note, I think from your reflections, the members will acknowledge what a complicated space this is and how much work there is that you have to engage with to make a meaningful difference, and how it is undermined when some of those bigger social fabric issues are not being adequately dealt with. So constantly we're responding and reacting. And I guess my response is I'm going to sidestep Honourable Member du Plessis' inputs, because I think a lot of that's been well covered. But just to highlight that we absolutely need to not be only looking at the response, the police response, on its own. We also need to see how best we can infuse the social support, the psychosocial support that you've mentioned. But that needs to be done at scale. And very often our response is the reactive one. What are police doing? And they are ill-equipped, I fear. And so we always need to bear in mind how we bring a stronger social work dimension into what we do. I'm going to try and respond to Honourable Member Fenny's remarks. I didn't get a direct question in there, but I'm going to try and synthesize some of what I've heard. So to begin, and just to note, I don't think there's any dispute that our history, colonialism, apartheid is an act of violence. We acknowledge the structural violence that has happened in the past. In fact, it fits very well with the World Health Organization's definition of violence, if you read between the lines. So we talk about the intentional use of physical force or power that is threatened against oneself, another person, or against a group or community that has a high likelihood of resulting in injury, death, psychological harm, maldevelopment, or deprivation. So I think if you look at the broader dimensions of that violence definition, I don't think there's any question that our history has strong elements of structural violence. But, you know, South Africa is not unique in that respect. And in fact, of the risk factors that we've set out, none of them are unique to South Africa. Many countries have them, and the issue with us is we have so many of them in abundance. And I think your broader question then is, what do we do about it? So the first thing I would recommend is we need to disentangle this notion of crime and violence. They're rather different things. Many countries have high levels of crime, but it's not necessarily as violent as the crime we see in South Africa. Very few countries have levels of violence like ours, though. So I think the example you used was of robbery, and as an attempt to a form of redress to combat inequality. I think the data that I've shared with you suggests that if you look at violence and homicide, very few homicides are occurring in that space. It's mainly between acquaintances. It's the psychosocial dimension. That's where the violence is happening. It's not where the crime is happening. It's where the violence is happening. And that's where we need to be focusing our efforts, because I think that is the particular flavor for South Africa that sets us apart in a bad way, is the level of violence. So agree, we have to address some of the bigger issues around inequality, employment, the social fabric that undermines the development of children over the life course. These are all long-term things. And so the challenge is, what do we do now? And what I've tried to highlight for you is that there are just a handful of things that we can do now that have a broad population level effect. But we need to get them right. We can't do them piecemeal, because otherwise you are giving Nobisa and Pinky and their team an impossible task, because as they make inroads and gains, we are not controlling alcohol, we're not controlling firearms, we're not doing the things that need to happen to give them the space to progress the science. So I think I hope that gives you something to work on. I'll pause there. Thank you.
Thank you very much, Dr. Shai, Dr. Mashlango, as well as Prof. Richard, for the very informative presentation, as well as the responses and reflections to the questions and comments of the honorable members. We really appreciate it. But I will release now the team, the delegation from the Research Council, so that we can proceed with our meeting. Thank you very much.
Thank you very much.
Thank you.
Honorable members, we are now at the next point on our agenda, and that is the consideration and adoption of the committee third-term program. That it is in front of us. Can we get a mover for the adoption of this program? Honorable members.
Honorable
Du
Bande,
Plessis.
I move for the adoption. I was struggling even to participate. It's very difficult to raise hands with the hand which I'm using at the moment. But I move for adoption of this program.
Thank you, Honorable Sibande. I was wondering where you are. And Honorable Du Plessis.
Honorable Chair, I second the adoption of the program.
Thank you very much, Honorable Du Plessis and Honorable Sibande. We really missed you, Honorable Sibande. In terms of the questions, now we are at the point of the consideration and adoptions of the committee meeting of 23rd of July. Honorable members, can I get a mover? Honorable Fanny.
Thank you, Chair. I'm moving for the adoption of the minutes, Chair.
Honorable Du Plessis.
Second the adoption of the minutes.
Well,
Thank you. Thank you very much, Honorable Du Plessis. Honorable members, we are now at the point of any other business. First and foremost, I just want to indicate to the honorable members, the officials, or it was indicated from the Parliament side that there will be transport available to the funeral of Comrade Baines on Friday, and there will be accommodation for the honorable members. But the honorable members from the committee must just indicate who will attend the funeral. And the other one is in terms of our oversight next week. It will be in the Eastern Cape. We will fly from our respective locations on Monday, and the oversight will be on. We will fly from the respective locations to PE on Monday, and the oversight visits to the two hospitals will be on Tuesday, and on Wednesday we will fly back to Cape Town. Honorable members, is there any questions of clarity regarding this two events? Honorable members, over to you. Honorable Makwele.
No, thanks very much, Chairperson, and greetings to honorable members, and also to say condolences to for us as the committee, first and foremost, because remember, in fact, we are the most immediate family members than even those that they were living with one of our own comrade or honorable Baines. So I'm saying that is why I'm saying that condolence to us, because we are very close to each other than the family itself, and condolences to the family and the whole NCOP. In fact, I'm covered by your presentation, because I was also worried that we need to indicate quickly, so that those that are dealing with logistics, they can finalize as soon as possible. But safe to say, Chairperson, I don't have much to say, except to say that we never see each other for a very long time, and we wish that coming back to this term, will be continue doing the very good work that we have been doing as the team. So those are my only comments. I don't have much to say. Thank you, Chair.
Thank you very much, Honorable Makwele. Honorable members, so my request is that we will just indicate on our committee group who will attend the funeral of Comrade Bain, so the logistics can be sorted out. So thank you very much, honorable members, and thanks a lot to the officials that is supporting us as a committee. We really appreciate your efforts.
But Chairperson, maybe if the last thing, man, just keep my mind. Is there any update regarding the progress on the issue of the preparation for the study tours?
Yes.
The issue of the study tours.
You can.
Chairperson? I was just saying that.
All right, we will request Can you hear me?
Yes, I can hear you.
Yes, Honorable Makwele.
Chairperson, I was just saying that, is there any update about the issue of our oversight tour that they were busy preparing, which the one that will be going abroad? Just to say if there is any update so far about the preparation, if there is any. Thank you.
Honorable Makwele, there is no update at the moment, but we will request Marcel and the team to prepare an update for us as the committee regarding our study tours. Honorable Makwele. So if there's nothing from anyone else, I will just thank each and every committee member, honorable member, as well as the officials supporting our committee for your time and efforts. So this meeting stands adjourned, honorable members. Thank you very much.